We do routine next-generation sequencing as part of research protocols at this time. I do think it's reasonable to consider thinking about tumor mutation burden when considering other therapies, although at the moment we only have one class of treatments, and so what is your alternative? Your alternative would be chemotherapy, which might not work very well to begin with. And so I'm not routinely using it as a decision-making tool today. I suspect in several years we'll probably have composite biomarkers that relate to RNA expression profiles, as well as tumor mutation burden and/or somatic DNA damage repair mutations, or even germline DNA damage repair mutations, all of which might lead to improved responses. But I worry that if we're looking only at one particular domain in terms of a biomarker, we're going to miss a lot of information. And we need to show that they're clinically useful and that they help us make a decision that leads to better patient outcomes. And currently, none of them have truly shown that because we really don't have an alternative for patients. There are many reasons why a tumor may not respond to immunotherapy. It may range from the fact that there are not sufficient antigens, that the antigens are not presented, that the immune cells can't get into the tumor, that even if they get into the tumor, the immune microenvironment is preventing them from acting. But a big step is getting the immune cells into the tumor, and there are a group of tumors that we call immune-excluded tumors, where the immune system can never really get inside the cancer and really be in a position to attack. And so there are a lot of approaches now that are trying to push the tumor immune microenvironment to accept the T cells into that environment and hopefully lead to improved immune responses. And there are approaches looking at TGF-beta, there are approaches looking at vaccines, there are approaches looking at changing the microenvironment through anti-angiogenic agents, which may have modulatory effects beyond allowing immune cells in, but also affecting the types of immune cells that get into the tumor, either reducing T regulatory T cells and decreasing MDSCs, myeloid-deprived suppressor cells, which would suppress an immune response and shifting that immune response. In addition, things like IDO inhibitors also work through changing the tumor immune microenvironment and changing the activity of different types of T cells that might be within the immune microenvironment. And so there are multiple different ways that this is being targeted. You can imagine 5 to 10 years down the road, in fact, we'll be using combinations of 3, 4, or 5 therapies that all do different things. The issue will be tolerability and can they be combined safely, which has been a concern for certain agents.